Right. Thank you very much for inviting me to speak. Before I even start, I want to acknowledge a couple of important team members who are in the audience today. And so they've made huge contributions to this presentation and to the Airborne Hazards Burn Pit Center of Excellence. So Dr. Inés Sotolongo, would you mind standing up? She is the director of the Airborne Hazards and Burn Pit Center of Excellence at the WRIISC. And Dr. Eric Schuping is in Post-Deployment Health Services. And he's the post-9/11 director who's in charge of the Airborne Hazards and Open Burn Pit Registry. And so if you have any questions about those two things in particular, I will also defer to them, or you can ask them at the break. So I guess my assignment here was slightly different than the other speakers. I'm giving more of a programmatic overview of what we're doing at the Airborne Hazards and Burn Pit Center of Excellence. And I think I'm hoping that this will provide some context and also maybe fill in some of the gaps that Dr. Falvo alluded to. I think some of the very interesting work that's happening. So you all know in 1990-91 we had Operation Desert Storm and Desert Shield, and service members came home and were sick. And this, a predecessor of this committee actually recommended that the VA establish a center that ended up being the War-Related Illness and Injury Study Center in 2001 to look at deployment-related health problems and to do research, education, and clinical care, as well as risk communication about deployment-related health concerns. I started at the WRIISC in 2001, and on day number 2, 9/11 happened, and very soon after that we launched a global war on terrorism. By 2004, we realized that we needed to not just look at Gulf War veterans from Operation Desert Storm and Desert Shield, but we would have a new cohort of veterans coming into the War-Related Illness and Injury Study Center, or the WRIISC as we call it. And so we established an executive evaluation for post-9/11 veterans. This was not unique to the WRIISC. There were other VA centers around the country establishing post-deployment clinics in order to facilitate the entry of these new veterans into the VA system. But it provided an opportunity for us to get to know this new cohort of veterans and to learn about their concerns and health problems. By 2007, we had actually reported on, in a small sample of our clinical patients, their exposure concerns, including burn pit smoke exposure and airborne hazards. And that information was shared around the country. And, there were screenings and all sorts of proactive steps to try to address these concerns in the clinical setting for veterans. By 2010, the New Jersey WRIISC had actually taken on the responsibility of conducting baseline pulmonary function tests as kind of a surveillance measure in these post-9/11 veterans, building up that clinical repository of information that Dr. Falvo was alluding to. And by 2011, of course, there was the first study by the IOM, now the National Academies of Science, talking about airborne hazards concerns. And really, I think one of the major findings was that there wasn't a lot of objective information available in the peer-reviewed literature. There were also some other reports that came out around the same time, and the first VA-DoD symposium on the topic was held. In 2012, Dr. Falvo already presented his pilot study, and by 2014, we had an Airborne Hazards and Open Burn Pit Registry. I was involved very much in the setup of that registry and have maintained an interest and engagement in the analysis of the registry data since then. By 2015, the New Jersey WRIISC and Office of Post-Deployment Health Services actually took it upon ourselves to create an Airborne Hazards Center of Excellence, building on our clinical experience and our research expertise at the New Jersey WRIISC. And we started publishing the data from the case series, from our clinical case series, as well as from the Airborne Hazards and Burn Pit Registry. One publication I do want to highlight, I think this might be of interest to the committee, is our analysis of the registry data looking at the association between blast exposure and persistent cardiopulmonary symptoms. That was published in 2017. And in 2018, Dr. Falvo was funded for his merit project that he also just presented. And finally, in 2019, the New Jersey WRIISC was designated as the Airborne Hazards and Burn Pit Center of Excellence for the VA. And I want to tell you a little bit more now about what we are doing now that we have that moniker and that responsibility. This is just a summary of our cumulative clinical experience at the WRIISC. Like I mentioned, the WRIISC is actually responsible for around airborne hazards concerns and some of the clinical data that we have available. The WRIISC is actually a research, education, and clinical care center, so we do all three, cover all three of those domains. And so the clinical experience is a very important part of what we do. You can see that overall we've had more than 500 referrals for airborne hazards-related concerns in both pre- and post-9/11 cohorts. And these are the folks for whom we have more in-depth, objective clinical data from pulmonary function tests, et cetera. So where are we now? Expanding the clinical capacity for evaluations of veterans with dyspnea and decreased exercise tolerance is a priority for the Burn Pit Center of Excellence. And we are very interested in leveraging the registry and the registry data to that end. There are pros and cons to the current registry, or the registry as it is now, but we are working very hard to utilize the information that's available in conjunction with other data sources to extract what we can from that information. The Burn Pit Center is also working very hard to enhance the basic and translational research with our academic partners, and launching a DoD-funded linked proposal with Walter Reed Army Institute of Research to further explore blast-related lung injury in veterans. Separate from leveraging the registry for improving access to and the quality of care, we're also mining the registry and linking it to other data sources to see if we can generate, and perhaps even in some cases test hypotheses using those merged data sets. At the moment, we're in a new fiscal year. Happy New Year, everybody. The money that was committed to the Airborne Hazards and Burn Pit Center in FY19 has been obligated and allocated to address the goals of the center. The center right now is actually hiring new personnel to expand the capacity and enhance the capabilities around clinical education and research. Our partners in this include VA New Jersey Healthcare System, Post-Deployment Health Services, the Office of Research and Development within the VA, and Employee Education Service. So once again, the Burn Pit Center has kind of that same three-part mission of doing education, clinical care, and research. And so it is not just research. We're also partnering with our academic affiliates, and so these are partners with whom we already have affiliations. We're interested in expanding that and working with other partners as well. And I think it's very important that Dr. Sotolongo and Dr. Falvo, who is the scientific director of the Airborne Hazards and Burn Pit Center of Excellence, are working kind of within the context of the WRIISC with its track record of success and its institutional support, but trying to build an independent identity and really a focus on airborne hazards and burn pit concerns of veterans. One way we're trying to build clinical capacity is by partnering with 4 other VA sites around the country to perform similar exams to what's been done at the New Jersey WRIISC. And so those sites are Baltimore, San Francisco, Ann Arbor, and Eastern Colorado. And we're working together with these collaborators to really establish a standardized clinical protocol that will be comprehensive in nature. And we're going to target 100 patients evaluated per year, which will increase the current volume that's being done in New Jersey, and I think will hopefully meet the demands of the patients. I think that's a consideration that we're still discussing. It certainly will expand the capabilities across the VHA system. You know, it won't just be one place in New Jersey that does this. There will be multiple sites kind of spread out across the country. And this is consciously designed to form the nidus, a clinical nidus for research. So the idea is that there could be investigator-initiated research projects building on the clinical experience, using the clinical data as pilot data, perhaps establishing a data and biorepository separate from the clinical evaluation, but kind of in conjunction with that. And once again, we're going to be using the registry to identify high-priority target subgroups for these evaluations. Just a quick update on the registry. Like I mentioned, Dr. Shuping is the guy in charge of the registry, but we support the evaluation and the use of the data. As of September 15th, there were almost 185,000 participants who had completed the registry. The registry exam, which is optional, has been completed on 11,500 people, of whom 8,000 or almost 9,000 are registry participants, meaning that more people have had this exam than have completed, or than, I'm sorry, let me restate that. Of the people who have completed the exam, not everybody has completed the online registry. And this registry is being completed and documented using the specific note title in the medical record at 119 medical centers out of 150. In terms of just looking at the chief concerns listed by the clinician in the notes, in these airborne hazards registry notes, the top 5, all of which have more than 50% of people reporting these problems, are shortness of breath, chronic sinus infection, runny nose, gastrointestinal problems, and decreased exercise ability. So not too different from what we've been hearing from the epidemiologic and survey-based data. In an effort to improve access and quality of care, we are summarizing the registry information and the registry exam information on a regular basis using standardized reports. These are shared with certainly internally to Post-Deployment Health Service and the Airborne Hazards Burn Pit Center of Excellence, but also to the VISN leads for environmental health and across the system and down to the facility level. So we're actually tracking this on a regular basis and letting people know how many people in their catchment area have registered, completed the exam, or completed the questionnaire online, how many people want an evaluation, and how many people are getting in the evaluation. So we're really trying to drive this and be proactive about getting everybody the care that they want and need. A couple of projects that are ongoing. We're looking at sarcoidosis as recorded in the registry and linked to the VA medical records. It's a case control study, and you can see the number of cases there, 454. We're matching on age and gender, and we're basically trying to generate some hypotheses using the data from the registry and from the VA medical record around the factors associated with sarcoidosis among registry participants. And we're similarly exploring the utility of the registry for looking at cancers. In this case, a rare cancer, pancreatic cancer, which has been in the media as possibly being linked to burn pit smoke exposure. And so we're trying to see whether we can actually do a case control study that might actually inform the field. So we're working on those right now. Where are we going? Definitely want to improve the veterans' experience with regard to getting attention, care for their exposure concerns, their airborne hazards and burn pit exposure concerns. We want to do deeper science. I think we all know that doing good science takes time and you're building incrementally. I think we would like the Burn Pit Center to try to accelerate that and do what it can to facilitate good science being done. I think we've got still a lot of questions about etiology, pathophysiology, prognosis, treatment and management of the symptoms, as well as how do we best implement evidence-based practices as they come online, or even just evidence-supported or best practices as we develop them. Once again, we have to be very proactive about our education and dissemination, as well as communicating about the risk and talking with our stakeholders about risk and their concerns. And of course, eventually informing policies that can be developed. I'd like to, kind of harking back to that history that I shared. I think our response to airborne hazards has been different than for previous generations of veterans and for earlier cohorts of deployed veterans. And I think it's going to continue to be better than perhaps those previous generations have experienced. I think the VHA, the Veterans Health Administration, demonstrated greater readiness to be proactive about addressing the concerns of this cohort of veterans. I think our ability to capture data is greatly enhanced relative to the mid-1990s and certainly to the 1970s. Data science, our molecular and omics research capabilities are just so much better now. I think there's a recognition of the need for team science. I think you look at this panel up here and you see most of us have worked together extensively, and we recognize the strengths that every different agency and every different group brings to this question. And I think we're engaging with our veterans in a better way that's more productive and helping us remain relevant and focused on their needs. And that's it for me.
Thank you. Questions for specific questions for Dr. Helmer? Right?
Yeah, I'm a little confused by your 8,845 participants, your 184,494 participants, and most particularly the 546 cumulative clinical experience. How do these relate to each other? Who are they?
So the 526 is our WRIISC clinical experience over the past 9 years, and so that's separate from the registry. So that you can kind of put that off to the side. That's people who have been referred to the WRIISC in New Jersey and have come in to have what we call an airborne hazards evaluation since 2011. So that's very separate from the airborne hazards and open burn pit registry numbers that you were citing. The 185,000 people are veterans and active duty service members who are eligible to participate in the airborne hazards and open burn pit registry.
And is that because they're in your catchment area? Or
no. This
else?
is national. That's the national registry. And that is a VA and DOD registry. And so those are people across the country. As a matter of fact, some of them are completing it while they're overseas. And then the number who have completed the in-person airborne hazards registry exam, that 11,000 number represents people who have a note in the VA medical record that reflects the title Burn Pit Registry Evaluation. And of that 11,000, 8,000 or 8,800 have actually completed their Burn Pit Registry online questionnaire. Sorry, I could give you a flow diagram that would maybe make that clearer.
Just had a related clarifying question. So in the 2010, when they started, there was an initiation of conducting baseline PFTs. That would be on a subset of the 550?
Those are the 550. That's when we started doing that, yeah. And that was just at the New Jersey WRIISC.
I think we're going to move on. And
can I just ask, how many of those were just post-9/11?
I had the numbers there. It was
I don't think I saw that.
so 215 were Operation Desert Storm and Desert Shield, so Gulf War veterans, and 257 were just post 9/11. Okay.